So thank you all. Let's see if I can work this here.
Right. Yes, sir.
No, that's a point. There we go. All right. First off, we want to thank the Academy for having us, and thank Lila and her staff for allowing us the opportunity to do this commission paper and to make the case. I'd also like to, of course, thank our co-authors, Ioana Staikulescu and Karen Edison from our Center for Health Policy. Unfortunately, they couldn't be here today due to other obligations. And then last but not least, I want to thank our plain language specialist who helped us. You know, one of the things that we have challenges in reaching policymakers, and so something that is accompanying this report, I don't think it's been released yet because we're still kind of finalizing it, is though we did a series of fact sheets that you can present to policymakers, and also he worked on the executive summary to make it more plain language so that we could put it in terms that were better understood and outside of that medical jargon and research jargon that we use. I'd also like to thank all the people I talked to. I talked to at least 50 different people across the field trying to find out what the new evidence was and the best and promising practices that are coming out of the non-peer-reviewed literature. There's a lot in the peer-reviewed, but there's a lot of stuff that just hasn't quite made it there, especially, you know, quality improvement work that hospitals are doing and things like that. And so we talked to quite a few folks across the country and got great input on the different perspectives about the case and the different parts of the case, because actually there are probably like 10 or 12 cases that you could make when it comes to health literacy. And so one of the first things that we wanted to start out doing is, as we started to do this work, we realized that there are lots of challenges to making the case for health literacy. Even with a strong case, there are things that our system has here, at least in the U.S., that creates different incentives and things that really kind of hinders the case at times. You know, the first, I think, are our reimbursement incentives. You know, we don't have a national health agency that regulates healthcare, so reimbursement kind of sets the stage for the way that we do our policies and deliveries in healthcare. And as we're still kind of transitioning to value-based reimbursement, volume-based reimbursement still dictates a lot of places, and unfortunately that does not incentivize good health literacy a lot of times, because if you don't do a good job, you just end up making more money when patients come back. And so as we move to that, I think, you know, that is something that we're definitely going to be moving to. I know CMS has said by 2018 about half of their reimbursement is going to be value-based. So I think that's something that more forward and progressive thinking health systems and hospitals and clinics are already starting to try to address. But it's something that we're still struggling with, because until we get those incentives aligned a lot better, that's going to be a challenge. You know, I think the other challenge that we have is that we don't have a very transparent health system. I'd like to thank Dr. Parker for a great conversation I had with her about this, because I mean, I think that's one of the real challenges. We want people to be active, engaged, whether you call them health consumers, health customers, but if you can't even shop around for price, or you can't tell the quality of the products you're buying, it makes it virtually impossible. And so that's why I kind of threw in this quote by James Dusenberry, who's an economist, but also a sociologist. You know, he says economics is all about how people make choices, and sociology is about why they don't have any choices to make. And I think that's kind of our dilemma in health literacy. We want to empower patients to make these choices, but yet they're working within systems and policies and structures that limit their choice at almost every level. And until we really address and tear down those systems and redo those policies, it's going to be very challenging for folks to even make well-informed choices when we do get the information to them in good ways. You know, another thing, and I'm glad Professor Trudeau is here to talk about law, because I think that's one of the challenges that we've experienced in our own work. We do a lot of plain language work, both within our health system and with the MoHealthNet program, which is Missouri's Medicaid program. And I can't tell you how many times we've reworked a document, we've worked it with patients so that we got it really well tested, we've done usability testing, all sorts of things. They take it back, they hand it to the lawyer, and the lawyer says, oh, we can't do this, and just shuts it all down. And so we've tried to get lawyer buy-in, and we are doing a little bit better and more successful with some of the younger lawyers who I think are starting to get it and get that fact. But until we really convince the legal profession that this is important and that you do truly have to use plain language to have true understanding and informed consent around those issues, then I think that's going to be another challenge. You want to come up? We're gonna kind of tag team this, so.
So as Stan was talking to people, we would discuss what Stan was finding out from his conversations and what I was hearing and what I see in the literature. We need research to support the efficacy of health literacy interventions. Most of the research is short-term based outcomes. Also, some concerns that Stan had heard from talking to folks informally was that, well, if we find something that doesn't work, we can't get funding. If one of our types of interventions doesn't work, then that's a challenge in terms of, like, can we get future funding for our project? We don't have we don't have an evidence base. So that's a challenge. There are to date, and I can speak with this with great confidence, there are no longitudinal studies that involve health literacy. Why? That's an area that we need, and also related to outcomes of cost, quality, satisfaction, and broad impacts of health literacy interventions. We have not done that yet, and we need to do that. It is something that we are limited by. We can't really say causal effects in any way. We could say relationships, but we can't say one thing causes another. And then as we were doing this search, particularly as I was going through this database that I've compiled over the years of the literature, peer-reviewed inside this country, outside this country, trying to find evidence that you could find research that may actually be about health literacy, but your traditional search terms doesn't turn it up. And Audrey, you're Dr. Riffenberg, you're shaking your head going, yes, yes. You could have research out there. So we admit that was something that was a challenge, trying to find everything that would fall within making the case and identifying this as a challenge.
And so when we look, we kind of divided the case into two key areas. First, what we would call sort of the business case, which really speaks to the different factors that go into the quadruple aim and speaks to hospitals. But then we're also going to present sort of an ethical case. And a lot of these overlap. You know, it's hard when you're talking about just looking specifically at outcomes, that those of course can translate to cost and things. So we try not to repeat from section to section, but a lot of these go hand in hand, whether it's the impact on behavior change, patient experience, cost, quality, access, all of those issues. And so don't think of these within their little silos as we're presenting them, because they can speak across many of these areas. And so when we looked at cost savings, and I know that there's a lot of literature out there, and that was one of the things that we didn't want to do, is really regurgitate what had been put out in a prescription to confusion, as well as, you know, the systematic review that was done by Berkman and company back a few years. So we were really trying to find new stuff that hadn't been published yet, or just had been published recently and hadn't been documented. But we found quite a lot of different ways that health literacy can improve cost savings. You know, whether it is like in this case with Mass General hiring what they call a community resource specialist. You know, they were able to cut their ER visits by 13%, and at the same time they increased their annual net savings by 7%, and they calculated their return on investment, and for every dollar they spent, they got about 150% back. So it can be a really good way to do that. Even simple things, we've got Michael Valere here with the What to Do with Your Child Gets Sick books, and those have been shown in many states to have a very positive return on investment. You know, even if it's just a 50 cents on the dollar sort of investment, that's still a good modest investment that we need in that return. And so those are some of the things. The other thing that we found is that a lot of times when folks actually did health literacy interventions, they increased their revenue by getting more people to actually come and show up to the ER and things like that, or show up for their screenings, or even just not have the no-show rates and things like that. There was an interesting study that looked at actually just using Teach Back at the front desk when you were giving out appointments, and it reduced their no-shows by, I think, like 15%, because people just didn't know when to come back. And so there are lots of things that I think we can do to really impact the cost. You know, our costs in this country are way out of control, and by no means is health literacy going to be the magic bullet. But when you think, you know, it's costing us anywhere between 150 to 238 billion a year, you know, that top number, that's 10% of our health expenditures. That can be, you know, that can actually make that curve flatten out on the cost side. And so we're really, really interested in trying to do a much better job at that. The behavioral case?
Yes, the behavioral case. So again, going back to the what to do when your child gets sick books, we found a non-peer reviewed study that when moms were given this with newborn children, they knew what to do, and there was less ER use, emergency room use, as a result of the moms having the books. They actually had like the resource at hand that was understandable, and they were less likely to take their child to the ER when the child was sick. Another example of colonoscopy patients, when they were given, or when they were phone calls made, interactive phone calls, heart failure, next one. When they were said, please call in, tell us what your weight is, monitoring, you know, like what's your weight this week, right? They saw decreases in the weight for heart failure patients. There is another example of colonoscopy patients, same sort of thing, an IVR, an interactive voice recording phone call, and they saw that those patients actually came in to have their colonoscopies, and then also do not only just the preventative, but then the maintenance and checking out over time. Adult education classes in which health literacy is added into, they saw, okay, the adult learners in that class, they had a boost in their knowledge in terms of health and what they need to do in terms of prevention. So these are like little itty bitty one-off places, but we see that there are these behavioral changes that happen as a result of implementing a health literacy practice.
And there's a lot more evidence in the paper. We just kind of tried to pick out a few sort of key findings to give good examples of this. You know, when we look at health outcomes, you know, I think this is one of the promising things that hasn't really been explored until more recently, these multimedia programs, you know, that now can be translated into YouTube videos and things, just another way to provide information to folks in ways that they can understand rather than, you know, just giving them the written information and trying to rely on that. And so, you know, we found that when they use those video education programs, they were more likely to be able to control their chronic conditions, whether that was high blood pressure or diabetes and glycemic control and those things. And even using interactive media and automated phone call support, whenever you can add that additional support to those media, we found some pretty good results. In this study that they looked at, they had a 15-day delay in readmission for chronic obstructive pulmonary, for COPD, and a 69% reduction in readmission length of stay. And as we know, you know, CMS is now penalizing folks for readmissions, and pretty soon I'm sure the private insurers are going to be doing the same. And that is one thing where there is a dearth of research now getting published, because a lot of hospitals have been struggling with trying to get those readmission rates down, and so they've been doing quite a lot. And there are a lot of good programs such as Project Red and things, and changing those discharge processes when people leave the hospital to make it so that they don't come back and they have the adequate supports. And I know at our own hospital, and this isn't in the paper, but we were struggling with our congestive heart failure patients, you know, asking them for their daily weights. The problem at first was we realized that a lot of folks didn't have a scale, and so we had to provide scales. And then we had to teach people how to use a scale. And then we were still struggling because we weren't getting as many back. And we realized that we weren't asking them what their daily weight was. We were asking them for their change in daily weight, which means they had to do some math too. And just changing that to report just the daily weight improved compliance by, like, I think about 18% within our hospital. And so it's just understanding these little challenges and being able to put in these supports to really help patients make those, you know, be able to overcome those challenges, especially when they're at home by themselves and not within the health system with that support. A quality improvement, that's obviously another realm, and this was actually a little surprising for me, because, you know, I've always heard, you know, if you look out there, ARC, CMS, everybody has a statement about how health literacy can improve quality improvement and reduce medical errors and things. But when we looked at the research, there actually isn't a lot of research that really tries to link and understand the causal relationship between health literacy's role and medical errors. There is a lot about medication adherence and medication errors, especially around dosing liquid medications. And so we've got some very clear guidelines that say, just simple things such as using milliliters as your main unit of measurement. That way you don't have folks who are trying to use teaspoons and tablespoons right out of their kitchen, that aren't standardized in those. Also using a syringe instead of that cup that has 20 different measurements on it is a lot easier to use. And so we've got some really good information out there around medication dosage, especially liquid, but we really need a little bit more in those other areas to really understand the role that misunderstandings and miscommunication play in those medical errors, especially outside of the hospital when folks are trying to remember that. One of the statistics that I quote all the time whenever I'm doing a health literacy talk is, we have several studies that have looked and found, it's kind of a range because of the different studies, but 40 to 80% of what the doctor tells us we forget as soon as we walk out the door, or if it's inpatient, the doctor leaves. But the scarier fact is the other part of that, the other finding in that study, which is 50% of what we do remember is inaccurate, because that's where those mistakes are going to be made that are really going to impact not only the health system and cost, but the lives and quality of life of those patients. And one of the things that I always like, we have a very complex healthcare system here, because I like to, when I'm teaching my class and my students, I like to stress that, we really have everybody's health system here working. We've got what you call socialized medicine in the VA and the Indian Health Service. We've got employer-sponsored health plans. We've got a national health insurance, Medicare, like they have in Canada. And trying to make those all work can be very challenging. But I always like to look at the VA, because I think the VA is especially leading the way when it comes to quality and other things. I mean, they have their own challenges and issues, of course, but they've got an electronic medical record that actually talks with each other across systems. I was actually really surprised to hear that Epic couldn't even talk with itself. I mean, I've struggled because we use Cerner and the other hospital in town uses Epic, and I've had to have them fax my records over there, and I think that's a sad fact that we're the only industry that still uses fax machines. I don't know anybody else who uses fax machines. There's a great blog on Vox the other day that went through that issue. But I love the fact that the VA is really trying to take attempts to do this. So they've developed a patient-centered medical or medication label to improve the quality of care. They're just now testing it and seeing how it goes. So I'm very curious to see a year down the road how much of a difference that makes in reducing medical errors. When you look at the cost data, for example, we have these great estimates by Vernon and others, but the only one who's really, that we could find in the research that really had studied costs was the VA system. And they looked at over 93,000 veterans, and they did a test to see what their health literacy was. And the ones who had marginal to low health literacy spent about $143 million more over a 3-year period. And that's just 93,000 folks that they looked at. So there's some real numbers. The VA has real numbers of the costs of health literacy and those savings.
Okay, in terms of the care experience, so Stan had to educate me on a lot of the H camps. Some of you, Cindy, you will be sitting there nodding in a minute. We found that hospitals that employed a commercially developed and implemented video program, they found that 100% of the hospitals who implemented that had higher H camps, literally meaning the top box percentages. The people would check off, yes, on the top box, that they were satisfied, their level of satisfaction. So we found that to be also unpublished, but a result that by using a health literate practice, such as a video programming, right, we can see those which matter to your CEOs of your hospitals, like those H camp scores are at the top box checkoff. You see major improvements. Satisfaction is further enhanced by telephone-based education and support services, going back to having an automated system that calls you up and says, hey, did you remember to do whatever it is you were needing to do in a polite way. Solutions don't have to be expensive. I heard to talk about the types of records or what's spit out when you're being discharged. I was thinking about a conversation a couple of months ago with some of the medical staff at Sparrow Hospital System, which Sparrow is our largest hospital system in Michigan. And one of the folks was saying, we get these sheets of paper when someone's leaving the hospital here, and it's got all this stuff, and it's really tiny, tiny, tiny text, and it's written all in medical jargon, and she said, I want to revise this. And I said, great, how do we do that? Well, we have to talk to Epic. So solutions, again, could be like rewording those if you can get buy-in, rewording reports, standardizing the emergency room instructions, make it, as I hear the customer, but I also hear the person-centered, like, find out. That's the issue. It's like meeting the people where they are at. Instead, we're saying, drag you up here.
But even I like the last simple solution, that there are studies that show that even just encouraging people to bring a family member improves patient experience and satisfaction. Very simple, but proven and effective universal precaution that we don't often talk about or encourage patients. I don't think that is actually one of the universal precautions toolkit. It's kind of in there in different pieces, but it should almost really be its own piece. And so let's talk a little bit about the ethical case. And really, I think everybody in this room knows we need to do it because it's the right thing to do. When it comes to just being an ethical and a much better industry. I like how Marty challenged us to not be that industry that doesn't take care of its customers and consumers and doesn't communicate well with its consumers, because I think that's one we just really need to get past that and become more customer oriented and customer focused. And so as part of the ethical case, of course, there is a regulatory case, and I'd say this fits in with the business case, of course. There are some regulations that are out there, mainly by CMS, that do require health literacy as part of their engagement. If you look at the conditions of participation for home health agencies at CMS or the guidance operations for long-term care facilities, they require that information be provided, one, culturally appropriate to, but in a way that the patient or the family and caregivers can understand. And so just, if there was kind of the CMS police out there, they could be taking away, the ability to be able to see Medicare clients and patients. The bigger factor, though, is really going to be that reimbursement change. Now we have MACRA, and that's starting to roll out, the Medicare Access and CHIP Reauthorization Act, which is setting up only two ways that physicians can get paid. You can get paid under what we call MIPS, or that merit-based incentive payment system, or you can get paid through alternative payment models, which do include, medical homes and things like that. But when you start to really dig into the policies, and we tried to provide a few examples in the paper, of, now we can actually get paid to do health literacy. I mean, you can do real health literacy changes and practice improvement changes and get paid for it, which is really a very promising thing. And one of the neatest demonstration projects, I have to talk about the ACA and health reform a lot, but one of the neatest demonstration projects I see coming out of the ACA is where they're giving, episode-based payments to physicians, and then you get your bonus based on your HCAP score. So the consumer actually has a voice in how much the doctor and the health system is getting paid, which, if we're going to be truly a consumer-driven system, that's a pretty promising thing. The other thing, of course, is that most state Medicaid programs, I was looking at this, and by now I think it's about 42 states are using some sort of alternative payment model to reimburse physicians, whether that's medical homes or health home models and things like that. Missouri's been doing health home models around mental health now for the last 3 years and really piloting some very neat programs that are making a big difference in the lives of those folks, because as we know, there are great disparities between those with mental health conditions and even mortality and those things as well. So there are a lot. I think as these incentives change, that's going to really start changing the policies and the way we do business. And I think it's going to be, though, it's going to hurt. It's going to be challenging, because we're going to, from a hospital perspective, we're going to go from a model that's more like a hotel where we're trying to keep our beds filled to a model where we need to keep people out of the hospital and really develop a true healthcare system instead of just having a sick care system.
In terms of health equity, and from a health literacy perspective, health equity means that everyone has equal access to health information that they can act upon, right? Making that case that health equity is vital. It's important that everyone is able. Why? First, lack of healthcare services. Folks who don't have the health information also, in many cases, lack the access to healthcare services themselves. Even if they have access to the services, the information may be fitting for some, or some may understand it, but not all. On top of that, if you read through, and I read through the wonderfully written, it was really, I'm serious, it was really well written, 2016 CMS Quality Strategy. Like, 2 goals in that strategy, particularly goal 3, enabling effective healthcare system navigation using health literacy, outreach strategies. That regulatory measure and that goal is very important to ensure that we have a system that is equitable, equal, across.
And so when we talk about the implications for health policy and practice, to be honest, you can't find anything better than the 10 attributes of a health literate organization. They really lay out the roadmap for, once we make the case, what facilities can do to really address that case and make a difference. And so I'm not going to, I know that these have been talked about and there was its own workshop, but I just wanted to send out kudos again and we cannot stress enough those 10 attributes and how well we need to integrate those into our system. And I'm hoping that one day when we do get a health literate organization, and if somebody knows one that does all of these 10 attributes, I'd love to talk to you more and learn more about it. But I'm hoping that, someday, we talk about everything we measure in healthcare and all these things. If we can do meaningful measurements in healthcare around health literacy, then hopefully this will be the way the health team reacts. I don't care what that is. Is that a cost report? Is that a quality report? Is that a medical error report? When the healthcare team is suddenly doing this, and two, I think this really speaks to the provider experience. And that was one gap that we did find. There's very little evidence that has looked at the provider experience and the impact on health literacy. I've heard a few things. I know Laura Noonan talked a little bit about integrating Teach Back at a conference, I think it was like 3 or 4 years ago, and you were talking about a little bit how actually doctors had to spend less time with patients because they weren't using extra jargon and having to re-explain things. And so, when we really get to there, when it can make a big difference to the physicians, because I think, I don't want a doctor bash or anything, but I think physicians you're challenged. Yeah. Having to try to do these within the current incentivized system, having to try to have a good conversation with a patient when you've only got 12 minutes. That's another challenge to health literacy. And hopefully once we can get these systems all on board and the policies and structures changed, then the healthcare team will react a lot more positively and it will impact their experience as well. So now we're going to talk a little bit about the gaps that we found.
At the end of every section, because there was a lot of overlap in the sections, we kind of made this recommended areas for future research. So this is kind of where I go in a little nuts, so I'll admit. So let's go back and talk about longitudinal studies. We need one with broad-based health literacy activities. In other words, put different activities across each other, or put them together, put them across groups. Let's look over time and see what happens. Does anything change? We need that. We also need to talk about looking upstream, the public health literacy approach. Instead of catching people as they're falling off the cliff or falling off the river and being sick and catching that person there, what about the more preventive measures upstream, looking upstream and trying to accentuate prevention? To ensure the information communication technology. So this and what I do right now is focusing on how the use of, let's say, for example, this thing, or your computer, or just regular landline. How can we ensure that those are being translated, that the use of these technologies are being translated into better health outcomes? There is very, very limited research, particularly in the United States, about e-health literacy interventions. We need to understand the direct relationship between health literacy and medical errors. We need to examine the link between health literate organizations and patient-provider communication to understand that relationship between health literacy and provider satisfaction. Like if a provider is using health literate techniques, are they happier? Are they more satisfied? That's an area we need to look at, looking at the provider in addition to every other component that we look at now.
And then our last challenge, when we really look at health equity, and I'm from the health equity, I do a lot of inclusion and diversity work, and so I just love this graphic that describes the difference between equality and equity. And so equality is kind of that first box where we give everybody the same box, but then some people can't see over that fence to be able to see the game. Equity is where we understand those differences and we try to provide different supports to patients. And I think that's where we kind of are right now. We're trying, and that's where the field first started out. Let's identify our health, or our patients that struggle and are challenged by health literacy and try to give them a little extra support. I really think, though, we need to move to that third picture, where we realize that it's that fence, it's the structures and policies, it's the fact that we don't have EM interoperability, so we have to rely on the patients for their information. It's the fact that we have siloed and disjointed health care. That's something that stares patients in the face. It's the fact that we don't have a transparency of information across that. There were several of these themes that I think the patients, both Jennifer and Marty, highlighted this morning, that's what's keeping people from doing this. We need to tear down those systems and recreate those systems so that people can see through that fence. Then we don't have to worry about providing special supports to these folks, and we do really create an equitable system for everybody to be able to navigate and get in the game, so to speak. And so we'll end it with that, because I'm getting my 2 minutes, and we'll ask, what questions do you all have?
So thank you very much for presenting the paper. Very helpful, and it'll be helpful in discussions as we go through the day. So thank you both very much for an animated discussion. Okay, we will open up the conversation from the floor for the roundtable members first, and then from the audience second. Terry, I see you coming to the microphone, so go to it.
This is just a comment on the literature.
Just identify yourself.
Oh, I'm Terry Davis from LSU Medical Center in Shreveport. Things I wrote 25 years ago were based on the evidence that I had then. And people will quote me back, this is the way it is. And I thought, well, I've done a lot of research and a lot of thinking since then, and things evolve. And that got me thinking, too. I think sometimes healthcare is, if we just say this is what's in the literature, because that's where the evidence is, but sometimes the culture, everything is changing so fast. And 2 of the research projects I'm on now, those phone call promptings, people don't answer the phone. I don't answer the phone if I don't know that number coming up. They're going to sell me something. I'm not answering it. And so right now, texting is doing a little better. Who knows in 2 years how people, I can't get a hold of a resident unless I text him. He won't answer an email or a phone call. Who knows the best way with the age group and their skills set. The other thing, I want to give a shout out to you. I don't think it's just,
Can't hear you, Ruth.
Okay. I think I'm on a transition of care from hospital to home, and here's what I've realized. Caregivers are so important, family caregivers, and this is going to be huge as we're all aging, and many of us are going to get dementia. And we're going to rely on somebody. And the literature is full of the system and what the system needs to do. There is a little shout out to the patient, but very little about the role of the family caregiver. And my hunch is, even if you weren't well connected with the health system, you weren't ready to let your husband go, and you would have stood up and done something. So
pretty good at changing room backs and all.
A lot of times family caregivers have to do skilled nursing care when they get home without good training. I'm sorry.
Larry?
Yes, hi. Larry Smith, I'm the physician-in-chief of Northwell Health, and I just want to give you a few reflections as I've listened to both the amazing presentations by our first two patients, now turned advocates, and you guys. And one is that health literacy, the way it's been presented so far in these two presentations, to me says we have to teach patients two things. We have to teach them enough information about their illnesses so that they can be legitimate partners with the healthcare system in the appropriate management. And then we have to teach them how the healthcare system works, which will be filled with cynical comments and all kinds of bizarre descriptions of how it actually works. But in fact, if the patients don't understand how the health system works, they will be endlessly surprised by the potholes they stepped into and the manholes without covers and all the other traps that we have set for people who don't really understand how the health system works. I listened to you, a suggestion you threw out there that we should change the language of radiology reports, or MRI reports, I think you said. And I'm concerned about that because the precision of using medical terminology in a report intended to go from one expert to another expert, to be watered down to be in the language that a layperson can read and understand the story behind that, I don't know that those are the same things. And I would actually strongly object to someone changing the way a neuroradiologist reports findings on an MRI scan to a physician who ordered that looking for specific things. On the other hand, perhaps we need a final box, which is what is the message to the patient who is going to look at their record, and what does this mean? The first 14 things I made note of are incidental and unimportant and should be disregarded, and here's the only thing the patient needs to know. And this is a tremendous cultural change, and I don't know whether medicine is ready or not. And then I think all the patients who feel like the system is really screwed up and worked against them in a fanatically meticulous way should understand that the doctors who are working that system are so unhappy. So we have 18,000 physicians at Northwell Health, and we do an annual survey, and one of the questions we ask is, do you think of leaving the practice of medicine early? If so, why? So the first reason, the second reason, down to the 35th reason is the electronic medical record. So everything pales in terms of the patient's dissatisfaction with that compared to the physician dissatisfaction with the electronic medical record. And you should know that Epic was designed for CFOs. So if you don't know that, and one of the vice presidents of Epic at a meeting of academic physicians glibly and kind of snotty said, "Don't you understand, we don't care about the doctors or the patients. We care about the finance people. And as long as they're happy, they'll keep buying our system for their hospitals." So, we're talking about a whole system that was designed to make everyone miserable except a very select people, and I can't even find them usually. I don't know who they were, but they're probably miserable too now. And so, all of this talks to how we have to partner patients and caregivers to just reconstruct this system. And maybe we can find the natural experiments that have already taken place with the few really, really great practices that are great communicators and health literacy teachers and see what's happened to their patients. Because I think we're more likely to find that than to do a randomized trial of those interventions. But those are my observations.
No, thank you.
Thank you.
Thank you for those observations. One of the things that brings up is, in my opinion, we kind of blame the victim here because we expect these individuals to have these skills, but we don't teach them that. If we truly wanted to teach health literacy, we would teach it in elementary and secondary education with reading, writing, and math. It's a life skill you need. And actually, somebody asked me last night, what was the most innovative study that you found in your research? And there was one paper that was published this year where they're actually democratizing medical education. They're taking what they would teach medical students and they're putting it into elementary and secondary education. And that's going to be a good way that we can start to get those life skills for patients. But until that happens on a larger scale, patients aren't going to have those skills. And when you're learning it on the fly, when you're sick, in pain, worried about a family member. That is not the most conducive learning environment to do that. The other issue with the MRIs, I will say the study they didn't actually reword the MRI report, but they translated it then into a way that was more easy to understand for patients, and finding those sorts of translation methods. And that's one of the challenges, I think, as we move more to these electronic systems. You know, my Samsung phone, before I got this phone, you know how many hours of end user testing it went through before I got to it to make sure that I could use it easy? We don't do that. Epic does it with the CFOs, but not with patients or doctors. And Cerner's the same way, that our doctors are just as fed up with our Cerner records as the patients are. But that's a challenge. You know, if we're going to be using that and going to open notes and things, and we've got to find new translation methods, because even if I can understand the jargon, I don't really like to read about what my problem is in those, you know, because it's always what this was the patient's main problem today. And those sorts of things. So the way that we word that, and I think just really better end user testing, you know, the golden rule of health literacy, and I learned this from Andrew when I first got in the field a long time ago, is to know your audience and test and develop with your audience. And I think that's something that the health system really does not do like other industries.
Just as another means of identification, Larry's the dean of the medical school at Northwell Health, in addition.
Oh. Hi, Kim Parson, member of the Round Table. And so I may sound like a broken record, Stan, echoing your comments that you made after I stood in line. But so I think that, yes, you know, 3 points. One is we've got to stop blaming people and instead trying to, you know, always find a reason for why it's someone else, and instead, you know, take responsibility. In my organization, we like to say it's not my fault, but it is my problem. And so, you know, I think that that's how we have to approach things. I also think that there is right and there is also right. And I understand that there is a need and there is a level of expertise in the way doctors communicate and use language, and that, you know, that language has great meaning, and it's very important to keep that, right? And but it is also then right to understand that not all of us have that level of training, and that we're not going to understand that language, and so therefore, you know, it is incumbent upon the system for us to, you know, design and co-create with the people who are going to be the receivers of this information, and for those that are going to be navigating the system. End user testing is great, but I think we should start with the user at the beginning. And the other thing that I'll mention is the importance of education and life skills and learning this. And I often hear people blame parents and you know, of our children today, and who are not getting what they need from their parents in terms of being educated on how to navigate these systems and whatnot. And so I would say, unless these parents are engaged within this system every day, and that changes, as Terry pointed out, it's impossible for those parents to educate people on everything that they're going to need to know. I navigate this health system based on the way my parent educated me, right? But that doesn't mean that I'm still interacting with it in the best way that is possible for me as a patient. So thank you very much.
Thank you.
Terry?
Well, thank you, Stan and RV, for your presentation. Terry Parnell, Health Literacy Partners. In your highlights around the care experience, you spoke about the video education, and that 100% of the hospitals that use those commercially bought videos had much higher top box HCAP scores. And I didn't look at it just now, but when I read it, I remember one of the references was Emmy, which is a company that makes those videos, and I just find that interesting in the work that I do with health literacy and patient experience. I was wondering if you could share a little bit more about some of the other research around that. I think it was around something with stroke, but more information around the other studies that supported that, if you recall. It's just really jumped out at me.
Well, those all
it's
come
very hard.
from Emmy. Those are all
It
from
was all
Emmy. Those
Emmy.
are all
Okay.
Emmy-based results from from people,
It was
organizations.
that single study that
There were
that showed
several.
that.
There's three.
There were several that we were given. Some have been published and made it into the peer review literature. That's the one thing that I think Emmy does a little better than other
Yes.
corporations is they partner with a researcher to make sure that they're truly getting good evaluation data. And there was some stuff that we got from other companies that it was
Right.
kind of hard to tell if it was really because they
that's my
didn't put their study
experience,
design and things like that. But at least from Emmy, they've got quite a few little sort of fact sheets and internal reports that document the use of their products and how that's at least made some differences. They also report when it doesn't make a difference because they've got some failures that they've then been able to correct and do a little bit better job. But there were I think 3 or 4 different studies that we used that came from Emmy publications.
Great, thank you. Because I know the work that I've been doing with patient experience, getting patients to look and interact with those videos in their language that's culturally appropriate, that isn't too long, you know, it was unusual, so thank you for that. And I just want to just put a little shout out. When earlier they were talking about what do we need to do to train physicians differently, I think we have to, you know, let Dr. Smith speak to how the medical school is starting with the physicians, and I can't speak to it obviously with great detail, but in the community, where meeting the patients where they're at their homes, on the ambulance, and I think that is an excellent example of, you know, meeting patients where they're at and having that foundational understanding really of health literacy. So just wanted to mention it. Thank you.
Yeah, I think we have some challenges with education. We've fully integrated health literacy across our medical education, so there's at least one touch point in every. We have blocks, and then we have clerkships and everything. But the problem that we have now is we haven't done our professional development with the attendings and the preceptors. And so the students come out of there all gung-ho, ready to use teach-back, and then they immediately get shut down by the hidden curriculum when they're practicing. And a doctor not understanding even what they're doing, saying, oh, we don't have time for that. And so we're trying to do a better job of getting that professional development out front so that then those students don't hit that sort of hidden curriculum wall.
You also have to get the terminology up front in addition, so that people understand what we're talking about. Wilma.
I believe
Laurie.
Thanks.
Wilma, Laurie.
Thank you. Hi, Laurie Francis with Partnership Health Center in Missoula, Montana. It's an FQHC, Fairly Qualified Health Center, and formerly from Oregon. So we talk about payment reform constantly in Oregon. So I'm going to ask you a question about one of those areas. And thank you for the health system, teaching patients to navigate health system, that I think was Larry's comment. I don't think there actually is a system. And I think we all know that. And depending on where you are, the system changes. And so we don't have one. And that's what makes it really challenging. And then I'm a nurse. And we often don't talk about team-based care in here as much as I would like to. And I know I am a broken record. But it's, you know, patient-driven, patient-centered, team-based care is been around for 20 or 30 years now at least. The doctor doesn't have to do it all. And most doctors, present company excluded, are not great communicators. And so, and there are a lot of people on a team that can be excellent communicators who are trained in communication techniques. So I wonder how to get that more integrally involved in all our conversations here. And then one of the things I had seen with physicians particularly is teaching motivational interviewing, health literacy skills, and sharing power with patients and team members seems like a great way to retain physicians. Physicians really enjoy it once they learn how to ask questions. So just thinking about that and this upstream work, we have an embedded residency program in our FQHC, and really thinking carefully about what allows physicians to stay in healthcare. I appreciate your slides on cost savings in Montana, which is a fee-for-service exclusively environment. Every patient in the ER is a good patient under the ACA. So we want to see them in the ER. We want to see them except for the rehospitalization is the only. So we're not yet there from a payment perspective either. But when you guys were talking about the VA cost savings that is associated with health literacy, did you look at I assume you did, what some of the underlying causal factors? Is it just health literacy, or is it the way perhaps the culture of the VA that's a bit different?
Well, in the VA study, it was a 3-year retrospective study where they had people take the test and they identified them, then they went back retrospectively through their records and just looked at direct medical cost. So they didn't extrapolate on as much on other factors that could be playing out in that. They were just really trying to tie it to health literacy. But it's a great article by Han. I would highly recommend, because it's the only one that's really tried to actually figure out, calculate real direct costs and not just estimates.
Great, thank you.
Wilma?
Thank you very much for your presentations. I have a couple of comments and questions, and one is, yes, I'm very appreciative that you brought up the point regarding bringing somebody else with you as another set of ears and adding that cultural piece to it. You know, in a lot of our countries, we don't have HIPAA. So are we supposed to bring someone and then sign HIPAA, you know, kind of thing? So just considering that. And then the other piece is I would like to make clear, wearing my interpreter hat, is that, yes, bring a family member, but not for that family member to serve as the interpreter, because it's robbing that family member of their primary purpose and that of being a support. So step down from that soapbox.
Definitely.
Right. Regarding my next question, perhaps it'll be talked about more later in the day, or perhaps it's too nuanced. But when we talk about providers, I feel, unfortunately, folks immediately go to the physician or nursing, where a physical therapist can be a provider, a speech therapist can be a provider. Anyone else within that scope, from the moment that individual walked through the door, can be seen as a provider, right? So I think we need to just keep that in mind as well. Regarding what we've discussed primarily today, the way I've interpreted is it's that, you know, we've had the discussion regarding with perhaps a focus on direct service. Whereas, for example, we have community-based organizations that the community trusts and go to. And so my question is related to performance measures. What considerations have been made? What came to your attention regarding looking at these measures through the lens of an organization that isn't specifically direct service, but does have an impact on those whom we serve and with whom we partner?
And there is some studies in the paper that we documented that we're looking more at public health literacy interventions, where they do come up with new measures. I know Andrew is using quality adjusted life years and things like that to try to use that as the kind of the measures to be able to see the effectiveness on cost, and you can extrapolate to some pretty I'd say extensive cost savings when you do that, and we think about that. And that's the other challenge, I think, is a lot of the research is really just focused on those direct costs. And what we need is a longitudinal study that not only looks at multiple interventions all at once, because we usually don't do health literacy one thing at a time, so it looks at broad interventions, but then also looks at those indirect cost savings as well, because there's going to be a lot. You know, we don't talk about the lost years of productivity that happen from the medical errors and people who die from those things, and that's a huge cost on society.
Or even going a step back, the actual implementation of this, you know, what would those performance measures look like?
I'm a little mindful of the time, so we have a number of people still at the microphone, so I'm going to ask you to stick to just one question so we can get through everybody who's up at the microphone. Stacy?
Yes, thanks. Congratulations for your great work. We spoke a little bit about educating people, consumers of healthcare, on how to become health literate. My 3 adult kids learned how to make change. They learned something about numeracy and even writing checkbooks about, you know, when they were students. Did you come across any pilots or any experiences of bringing health education literacy down to elementary schools, middle schools, high schools? Because I think once we get to the professional levels, we've lost a tremendous opportunity to teach our children about this. So I'm curious if you came across any work of these kind of activities being done in grade school or schooling.
Other than that one study, but we, you know, due to kind of the scope and nature where we were looking more at the business case around that, we we didn't go into elementary and secondary education because they don't have the cost outcomes or the impact on quality or anything yet. But I'm sure there's more out there. We just didn't include it in this as much.
There are studies, but they're in Europe. Primarily, the Europeans are conducting that type of research and implementing health literacy type curricula in their primary and secondary schools and seeing what happens to the kids over time. But that's, in the United States, haven't seen anything yet that I know of.
Hi, I'm Audrey Riffenberg, and I'm not a member of the roundtable, but I just got the nod from Dr. Rossoff, so I'm going to go ahead. And I just wanted to say, we're talking about educating medical students and people kind of in the pipeline to become physicians. I recently met someone who is a professor in medical school. They have health communication skills embedded throughout the entire curriculum, 50 hours of training. And I was so impressed when I heard that. I thought, wow, that's amazing. How did you get that on the curriculum? You know, how did you sell that? Well, let me tell you where she is. She's at Colorado State University's Veterinary School of Medicine. And I thought, OMG, you know, we're giving our veterinary students way more training than we're giving people. We're training to work with humans, right? So I said, when I asked how did we, on the curriculum, she said, well, you see, we don't have all that stuff that's in between. We were able to directly measure that if veterinarians spoke more clearly and were more what I said, well, that's health literacy. She said, yeah, I guess it is. If they were more health literate, two things happened. They found this out, and I'm just wondering, maybe too late to add research to the report, but this would be interesting to bring this in from another field. The two things that they learned was that people were more likely to come back or more likely to bring their pet to the veterinary clinic if they felt good about the communication with the veterinarian, and they were more likely to be compliant with the treatment. So, I mean, there's solid research on that, and that's how she sold that agenda into the curriculum. So, you know, it maybe worth looking at that field of literature. There's not very much. She's a pioneer. I actually just met her in person at the ICCH HARC conference because she received an award for innovation in this area. But it just struck me as something to really pay attention to.
Thank you. We have three people at the microphone, Jay, Andrew, and Cindy. So, Jay.
Good morning, Jay Duig with the Roundtable. Thank you for your excellent work on the paper, much appreciated. If the goal of the commission papers is to generate and focus discussion, you know, it's proof positive. So the Roundtable is always engaged, but you have us fired up today. So on this, so that's terrific. What are the barriers to conducting the future research that you identified? So you had those 6 particular areas for future consideration. I know you have the references in the paper, and I actually requested your EndNote library, which was extremely comprehensive. Thank you for that.
You're welcome.
And puts together, so it really indicates the breadth of research that you did across so many of the different experts and areas and databases. So what would you say are the barriers to conducting, whether it be research on the role of health literacy and medication errors or adverse events, research on health literacy and the use of technology? Because when we're talking about building the case for health literacy, it's there's the aspects and the positioning of it, this is why it's good, which can work fairly well, and we want to accept that. But for my own work, I'm within AbbVie's patient safety group. When I say this is what we can do to reduce medication errors, that's what turns things on and goes to the top of the priority list.
You want me? Okay. There are no incentives for folks to be working together on, say, long-term, and I mean from not only the clinical field, but also social science, behavioral science. There's no incentive system. There's grants, particularly like NIH funded. I'm not pointing out NIH, so if you're from NIH, I'm sorry. My name is not R.V. Rikard. There is no incentives. There are no cross-discipline incentive structures or incentives to have folks work together over long term to examine the types of questions you're asking, like medication, taking one's medication. Most of the research has been focused in the clinical area, and that you don't need a sociologist or a behavioral cognitive psychologist. You're focused in one area. So until that, for the research field, until that changes, until there's incentives for folks to work together, that's the main barrier.
Thank you.
Andrew?
Thanks. I'm not surprised. I'm Andrew Pleasant. I'm not surprised Jay and I are on exactly the same wavelength. So I just get to push you a little further because Terry opened the door by basically saying 20 years ago she knew all this. In your report, you also point out how much money has been spent. Fair enough. You also point out how much money has been spent on health literacy research. So what I'd like to do is push you a little further on what funders should do to improve this situation. I know you've talked about the longitudinal design, but that's not the same as a funding organization saying we're going to change the way we do business. So what recommendations would you make to funding organizations, largely speaking, and that includes much more than the federal government?
Well, one of the first challenges is, a lot of the health literacy research now is coming out of PCORI, but PCORI was founded by Congress, and so they can't do cost effectiveness research. And so we've got great research studies, but if you can't look at the cost effectiveness of it, then there's that missing piece. So I think the way that we think about the policies of funding agencies, and then granted that's a special case because it was created by Congress, but I would say that's a first step, is really to give more latitude to researchers to be able to explore the breadth of the issue.
Mm-hmm. And I would say approaching large nonprofit institutions, foundations, such as, I'd like to talk to Bill Gates.
Yep.
And what would you tell him?
Bill, if you want to improve the health of the nation, we have one big component in our hand, and we need your help. Please.
That's a good start. I'm just going to take one. Go right ahead.
Oh, okay. Well,
and then Cindy, you can finish up.
Yeah.
Stay right there.
Okay. I will. Give me a minute. Jeez. Casey Quinlan. I'm a civilian, for want of a better term. I'm not an academic, but I do write a lot about health literacy. I come from the patient community. I'm also a journalist. But I'm going to, sort of end now for something completely different. Yeah. How much of the barrier is created by the status quo about getting to this, created by the status quo? 3.5 trillion with a year, trillion a year. I mean, why would anyone want to change anything in that system? And, I think that there's sort of an untapped resource that has been mentioned a bit here, but patient communities, particularly those of us who have a lot of experience and a lot of system knowledge, we're already activated. I mean, we're already doing this work 24/7, 365. But trying to figure out some way of getting us into the system, as opposed to being this, thing that happens out here, and then we send people in, and it's like, we're like getting under the drawbridge. But where do you see, us helping circumvent that? It takes 17 years for 50% of clinical practice to adopt known science, because we'll all be dead by the time we see any change if that stays status quo. So what are your thoughts?
Well, I would like to see more funding projects that do tie in. You have your PI, your principal investigator, but we need CIs, community investigators, that are paid for their value, so they're an equal member of the team, and brings the community to the table as part of that planning process. I think that would go a long way in one, saving us research dollars, because a lot of times, we do all this great research over here, then we take it out and we do some end user or a focus group, but then we've got to go back and redesign it all, when we could just skip that redesign phase if we had involved them from the very beginning. But that's something I think that we've really struggled with, and we're getting better just across all the fields, whether it's health literacy, of that community engagement process, and really valuing and acknowledging the knowledge that community members and lay folks bring to the table, and not just the expertise that the researchers bring.
Let me say real quick, jump in on that. Working on giving, Flint, Michigan, what's happened with the water crisis. I worked several groups, and colleagues who are doing research in the area, but a component of that, and I'm thankful my colleagues have done this, is they do have paid CIs, paid community investigators. It's not a whole lot because we're not getting a whole lot of money, but it is something. And we really listen. Like that when the community investigator says, "No, that ain't gonna work," I'd throw that out. Let's start again. What do you think? And so it's building that exchange and relationship and really valuing it.
Last question, Cindy.
This is along the comment lines rather than the question lines. So I was really pleased to see you address both the business case and the ethical case in your paper, and it reminded me of a paper that I wrote with Irene Fraser 15 years ago on the business case for cultural competence. And what I called like the rights case is a really important one to make when I talk about cultural competence, but it also fits in with health literacy about interpreter services. It's like, even if it doesn't save you money, even if you can't prove, clinical changes of outcomes, and there is actually some very good research around interpreter services, but I have a right to be able to communicate and understand and be understood by my healthcare providers. So I think that is actually a very strong message for mission-driven organizations. But we've also talked a lot about, the importance of the CFO, and when the innovators, the investigators who developed the re-engineered discharge, the RED, which is a health literate practice in hospitals, the investigator brought that to the leadership team at their hospital and said, look, we did this randomized clinical trial. It shows that we can reduce readmissions and visits to the emergency rooms. And the CFO, that's the chief financial officer, said, and why would I want to do that? Now, along Terry's lines, things have changed since that day. Now there are actually financial incentives to reduce excess readmissions. So I just wanted to spend a moment parsing out parts of the business case that I think it might be helpful to distinguish. So one part of the business case that I'm not sure that I heard or saw was around the market share, about loyalty, about leaving a provider that you're not happy with because of the way they communicate poorly or don't spend time with you, or some make it difficult for you to get to the next place. So that also can be part of the business case. And then there are incentives now, so that the incentives that I just talked about are one brand of about readmissions. There are also incentives that you raised, which I would put this in the business case about MACRA and MIPS, which are the Medicare incentives. And those have two different pieces to them as well, which is, one is the caps. You talked about the hospital caps, which is actually not a satisfaction survey. It's a survey of patient experiences. And so it's the patients telling what it was that they experienced, including a doctor who did not explain things in a way that was easy to understand, or a nurse during that. And so they get some of their financial payment based on getting those good scores. So that's a motivator. They're also getting paid for clinical outcomes. And so if you believe the logic model of you are actually going to get, better adherence, reduce unnecessary care, et cetera, when you observe health literacy universal precautions, then you're also going to want to do that because it's going to get you better outcomes, even from just business perspective. So I just wanted to sort of point out that there are a lot of levers for trying to appeal to different parts of the health system as to why they may want to embrace and become health literate.
Thank you very much. So this has been a good analysis of the paper. I think you'll hear more about this later on. You made my job later on in terms of making the case for the quadruple aim much easier, and we'll get into that during my presentation. So thank you very much. We have about 15 minutes now for a break, and then we'll come back and complete the morning session at about 11.